Subra, Gopi, and all my good friends in Calcutta. This is an evolving concept that is going through my mind, and I thought I'll share with this platform in Calcutta. How biology influences your ACL reconstruction and how we can improve the biology of ACL surgery is the thought that was going in my mind, and I've got few cases to show to you, and I'm sure it will add value to your clinical practice. Why this thought process? Because ACL is the most commonly injured ligament, and the surgeries, if you see that it's close to 2 lakhs, and around 1 lakh are the common surgeries that are performed in states. But having done so many surgeries all across the world, we still are trying to find out a good outcome for a classical ACL reconstruction, because there are umpteen number of techniques to do ACL reconstructions, and the biomechanics of understanding of how ACL is injured and how it has to be rehabilitated after reconstruction, and what are the other structures that influence the outcome of ACL reconstruction is evolving. As a result of which, it is important for us to go through this process of adding a new thought process of why biology of healing of an ACL reconstruction can be enhanced and how it will add value to the outcome. When we do a relook at the anatomy and the complex multifactorial causes for a failure of ACL surgeries, it is often pointed out that it is the technical failure. Apart from technical failure, you can see there are so many grafts that Arvind is harvesting. Is that the cause for failure of ACL surgeries because of the choice of the graft, or we don't address the anatomy in itself properly, or we don't do it at a proper time? Because there was a discussion going on which is the right time to do an ACL reconstruction or a ligament surgery. So it is important for all of us to understand, and it is important for us to find out what is the primary cause for a failure of ACL surgery. So in that line, we have just changed the way we do our procedures here. We don't remove a bit of fat pad from the knee. And how we do that? We go a little high on the anteromedial and the anterolateral portal. Our first vision that comes to the scope is the ligamentum mucosum. We release that, and once we release that, it falls down like a curtain and the fat pad retracts by itself. And once we do that, the fat pad is an important living tissue that is there within the knee joint. It beats for the heart, it beats for the function of the cartilage, the biology of the ACL and the tissues around. It is richly vascular, lot of proprioceptive fibers are there in this fat pad, and if we inadvertently resect, we know that it can cause arthrofibrosis and anterior knee pain for most of our patients who may harvest a graft from the front of the knee. So yes, preserving the fat pad will add value to your outcome of your knee surgeries, and that should be the first thought process that you should remember. The second thought process was, should we resect the hamstrings at both ends, from the tibial end as well as from the femoral end, or preserve the ACL semitendinosus and gracilis stump at the tibial side? By preserving so, we will preserve the biology of the graft, meaning the vascularity of the graft, and by doing so, we will help in maturation of the graft, healing of the graft, as well as prevent tunnel dilation, which is very common in a soft tissue graft when we use a semitendinosus and gracilis. Mind you, we will always get an adequate length of semitendinous, as Arvind was mentioning, but there will be a possibility that the gracilis will be little short, around 20 to 25 centimeters in an Indian scenario, and especially in South Indians it will still be short. So we can augment that by increasing the length using a fiber tape or a fiber wire, so that we can use it for our reconstructions. The third point that I want to tell you is, we always do what is called as an outside in drilling, wherein the ACL and the ALL that we want to reconstruct on the sides. The reason being, if you read through the papers of Ferretti and Philip Nere and others, and even Stephen Zaffagnani's papers, you will see that around 40 to 60% of the tissues are injured on the lateral side. Whether we do LET along with an ACL reconstruction, or whether we do an ALL with an ACL reconstruction in a younger individual, it will add value to your outcome of ACL surgeries, because nowadays it is understood that only ACL alone in itself will not give you optimum results. There is a chance that the lateral structures also will be involved, which commonly in the X-rays are reflected as a Sigon's fracture. So in that area, if we reconstruct both the ACL and the ALL together, there is a possibility that your outcome will be much better. So the third point is to reconstruct at the isometric point on the femur side for both ACL and ALL. Why we should do that? There is a great anatomical thought that has been percolated down from history immemorial. You can see that Houston, and along with the current concepts written by Volker Muschal and understanding by the Santee team, the thought process is that we need to catch the lateral structures and the intra-articular structures at the same point. When we do so, the multifactorial causes that are responsible for the instability of the knee can be addressed in one shot. That should be the fourth thought process that should be remembered by this august gathering today. And the fifth and the most important thing is, we need to know that we need to preserve a remnant, which in the earlier days were thought to be bane rather than being a boon. But those findings have been now put to rest, because there is no cyclops formation, or even if it forms, it will be of minimal. It will not cause an extension deficit or arthrofibrosis. In addition to that, we can understand that it will improve the vascularization of the graft, improve the tissue remodeling, proprioception, and objective functional capacity of the patient will be greatly improved. Yes, there will be a debate on whether there is an adequate evidence for this. Yes, there is a promising evidence that is coming out in the literature saying that there is a quality evidence to use the remnant to improve the biology of healing of the ACL when we do the surgeries. So whether we do a single bundle reconstruction or we do a double bundle reconstruction, we were doing remnant preserving surgeries. But yes, we need to incorporate that when we are doing surgeries both on the medial as well as on the lateral, intra-articular as well as on the lateral side of the knee. So the fifth point is, try to preserve your remnant as much as possible. Do not deface the intercondylar area or on the femoral side. That will add value to your recovery of the knee. So let me illustrate by a case. He is a 34-year-old football player with pain and instability in the knee, who had failed a cricket player who had failed a conservative management in the knee. And these are his clinical findings. If you see on the X-ray, there was an isolated ACL injury with instability, and we performed an ACL and ALL in a single sitting, and this is how the surgery goes. We generally mark the anterolateral side of the knee. ALL tunnel is drilled first, and then you can see the intra-articular part, the ligamentum mucosum comes into view. Underneath is your ACL, which is torn. Once we release the ligamentum mucosum in this fashion from a high anterolateral portal, you can see that it falls off like a curtain and the fat pad is retracted. We drill the anterolateral tunnels for the ALL reconstruction in such a fashion. Sutures are used to shuttle the subsequent ALL reconstruction that we do. We mark the lateral epicondyle just above and behind the lateral epicondyle, which is shown by the fat pad. We identify the hamstring grafts. We preserve the tibial attachment. Semitendinosus is around 30 centimeters. Gracilis will be around 27 centimeters. We tubularize the graft 3 times for the semity and 1 time for the gracilis. And the usual size of the graft will be of 7.5 to 8 centimeters in length. 8 to 8.5 will be the diameter that you will get. We soak that in vancomycin gauze and keep it in the anteromedial side of the knee while we drill the tunnel for the femur in such a fashion. We also recognize that the posterior wall of the femoral condyle should not be violated. We are mindful of that. Sequential drilling is done from outside in for the femur in such a fashion. All the debris that is there is sucked out by the shavers, and we use a suture shuttle to shuttle the graft on the femoral tunnel. The remnant is preserved on the tibial side in such a fashion. We do sequential drilling to preserve the remnant as much as possible on the tibial side as well. Once that is done, the shuttle is taken with the help of the suture grasper through the tibial tunnel. The passage of the graft is then done in such a fashion, and it is held on the femur side in tension. You can see the intra-articular part of the graft going through, and the graft is now secured at the lateral epicondyle with the bioabsorbable screw. You can put a screw on the tibial side or can leave it alone. The choice is the surgeon's. If there is an explosive pure shift, we take the ALL under the LCL. If there is a grade 2 pure shift, you take it just under the IT band and over the LCL, and then do the ALL reconstruction in such a fashion. The suturing of the ALL is done in complete extension with the remaining tape that is there on the ACL graft. You can see the tension is good and there is no impingement of the graft of whatsoever. Once that is confirmed, we come back and check whether there is lacement. The knee should be in complete extension. Full range of knee motion should be there as described by shell bone. Anterior drawer is stable, and you should be bold enough to do this pivot shift if you think your fixation is great. This is our breakup of the cases, and the average number of patients age is between 19 to 36 years, and most of the patients were equally distributed on the right and left sides. And in some cases, if the diameter of the graft is less than 7 or 8 centimeters, we'll enhance the graft by using a free strip of the IT band. That is a trick that you can use if your graft diameter is less. So why we should do this? If you see the stability study done by Alan Gatgood and its team, they proposed, or they are a greatest proponent of doing lateral extra-articular tenodesis whatsoever when you do with the ACL reconstruction. We all know that now ACL reconstruction isolation will give inferior results, and the 2-year outcome given by Alan Gatgood and his team is great, and I urge everybody to go through this paper to add value to your practicing of ACL surgery. Now when we do ALL along with ACL reconstruction, the chances of re-injury for the ACL graft is less. There is improved clinical outcome which is shown in the literature as described by Laprade and his group. And also when MRI studies have been done, they show that the graft matures nicely. And we all know that the total ligamentization of the ACL graft will take over 3 years. But when the graft matures early, we can get the patient back up and about, as our colleague was showing in the earlier presentations. Santi group proponents, Cortret and his team, have done a very large amount of study of a group of 2,800 cases to be very precise, and which they divided into 2 groups, and they found out that the bone patella bolt tendon graft, which we say is the gold standard for ACL reconstruction, if done in isolation, gives 3 times inferior results compared to a soft graft which is tubularized, which is done along with the ALL reconstructions. So my dear friends, at the end of this presentation, if you have to take home something, I urge you people to respect the biology to improve the outcome of your ACL surgeries. And though we know that technical failures are the cause for re-injuries of the ACL reconstruction that we done, it is also important for us to understand and respect the biology to improve the vascularity, graft maturation, and functional outcomes of the ACL surgery. And to know more about how these ACL surgeries are done,